Hi, everybody. My name is Adam Pick, and I'd like to welcome you to the webinar titled Advances in Aortic Valve and Aneurysm Surgery. If I have yet to meet you, I'm the aortic valve patient who started HeartValveSurgery.com 15 years ago in 2006. The mission of our website is very simple. We want to educate patients, their family members and friends about valvular conditions and treatment options. And this webinar, which has had over 980 registrations from patients in countries all over the world, was designed to support that mission. Now, throughout the webinar, you're going to be in what's known as listen-only mode, but I would encourage you to submit your questions in the control panel that's on the bottom part of your screen, and I'll explain why in a second. As for the agenda for today, I'm going to start with an introduction of our speakers. We're then going to talk about aortic valves and aneurysms, then have a very in-depth conversation about the treatment of those cardiac diseases. We are going to then do real-time Q&A based upon questions submitted by the patients in our community. And lastly, I'm going to ask you to complete a very quick 5-question survey. So that's what we're going to do today. When it comes to the featured speakers of today, I've got to tell you, I'm not only honored, but I'm completely humbled that they are taking time away from their incredible practices to spend it with us and be with our community on such an important topic. And let me introduce them to you. Dr. Joseph Bavaria is the Vice Chief of Cardiovascular Surgery at Penn Medicine Heart and Vascular in Philadelphia, Pennsylvania. During his extraordinary career, Dr. Bavaria hasn't performed 2, 5, 6, but 9,000 cardiac procedures, of which more than 6,000 involve some form of heart valve repair or replacement. And when it comes to his specialties, Dr. Bavaria is not just nationally known, he is world renowned for his commitment and dedication to aortic valve disease and aneurysms. He is a co-director of the Aorta Center at Penn Medicine, and he is so revered by his peers and his colleagues. Dr. Bavaria is a past president of the Society of Thoracic Surgeons. So it is great to have him on the call. And I've got to tell everybody out there, the first time I heard about Dr. Bavaria was from who? His patients. As I started HeartValveSurgery.com, I started hearing from all of his patients saying, God, I'm getting the best results. And I got to tell you, Dr. Bavaria is an incredibly nice person. So Dr. Bavaria, thanks so much for being with us today.
Thanks, Adam.
And Dr. Nimesh Desai is the co-director of the Aorta Center, and he is a director of the Thoracic Aortic Surgery Research Program at Penn Medicine with Dr. Bavaria in Philadelphia, Pennsylvania. Similar to Dr. Bavaria, Dr. Desai is an aortic valve and aneurysm expert, and he is also very interested in utilizing minimally invasive techniques to treat these disorders, one of which being transcatheter aortic valve replacement. Throughout his career, he's performed over 4,000 cardiac procedures with more than 2,500 involving heart valve therapy. And I've got to thank Dr. Desai, who's helped me and our community just most recently learn all about reoperative techniques in a video we filmed together. So Dr. Desai, thanks so much for being with us today.
Thank you, Adam. Thanks for putting this together.
Yeah, so why don't we go ahead? I could talk on and on about all of the accomplishments, the accolades, the achievements of Dr. Bavaria and Dr. Desai. It's clear we have a dynamic duo with us today. But instead of just going through all those great things I could say about them, I would like to show you this, which is the smiling pictures of the success stories from Penn Medicine, whether it's John, Stephen, or Mark. And John, by the way, is a NFL football player for, I think he's retired now, but he was at the Philadelphia Eagles. In addition to all the smiling faces you see here, there's the names. And these are all patients from the HeartValveSurgery.com community that have gone to Penn Medicine and had successful therapies with Dr. Bavaria, Dr. Desai, and their team. So again, I'm incredibly honored to have both Dr. Bavaria and Dr. Desai here. And to start this webinar, we're going to turn it over to Dr. Desai to learn all about aortic valve disease and aneurysms.
Thank you, Adam. That was a fantastic introduction. And it's such a privilege to talk to so many people from around the world today about something that, although it sounds like a cliche, is very near and dear to both myself and to Dr. Bavaria. It's what we do every day. It's what we think about every day. So we dream about at night probably as well. So if you go to the next slide. So let's start with some basic principles. And you know, the audience here from the questions is super knowledgeable about the aorta and the aortic valve. And I don't want to make this too simplistic, but for those who need an introduction, the aorta is the big tube, the pipe that carries blood from the heart as it squeezes it out, oxygenated blood, to the whole body to give it nutrition. And the entrance to the aorta is actually where the aorta meets the heart, and that's called the aortic valve. And the aortic valve is a one-way door that opens when the heart squeezes, so it lets the blood out of the heart. And when the heart relaxes, it closes. So the blood keeps flowing in a forward direction. Next. The area of the aorta we're going to talk about today is that part of the aorta really close to the heart where that yellow arrow is in the figure with the person there. And that is the ascending aorta and also the root, which is the part of the aorta that actually attaches into the heart and has the aortic valve in it. Next. So the reason we're doing this together, aorta and valve, is because the aortic valve is the aorta. So when we're developing embryologically in utero, the heart starts as this tube and then eventually it kind of turns and becomes this like amazing chambered structure with 4 heart valves in it. But if you look at the panel on your right there with the yellow, yeah, exactly, what Adam's pointing to there, you'll see that the aortic valve actually grows out of the actual wall of the aorta. That's why when you have a disease in one of these things, you often have diseases in the other. And so the concept of the aortic valve and aortic aneurysm are very tied together. Next. So the next question is, what is an aneurysm, right? Because we're talking a lot about aneurysms today. What is an aneurysm? An aneurysm is when your aorta is enlarged or it's bulging out. Some people will call it like a bubble on the aorta, which isn't really true, but it's a bulge or an enlargement of it. And it happens because the wall of the aorta has weakened somehow. And if the whole wall has weakened, you have a true aneurysm. If there's a little focal area or a small area of weakening, you might have an ulceration or a pseudoaneurysm, which is just a fancy way of saying an ulcer or a small hole. And if the wall splits and you actually have blood flowing in 2 channels in there, and I'll go into this a little bit later, that's called an aortic dissection. And obviously, that's a really dangerous thing to have and can be very life-threatening. And we'll talk about that a little bit later. Next slide. So what's a normal aorta? Well, a normal aorta kind of depends on a few different things, but for the average person, it's usually less than 3.5 centimeters. Anything up to 4 is usually not too concerning. But once the aorta gets larger, it has a risk of actually developing an aortic complication. And what that means is something bad happens to the integrity or the wall of the aorta and it tears. And it can either tear and develop into something called a dissection, or it can tear and actually rupture, which is where you just kind of bleed out, which is really bad. So these are things we want to avoid. And this is why we care so much about monitoring people's aortas and identifying aneurysms and repairing them before it's too late. To put it in context, typically when the aorta starts to develop complications is a little bit more than 5 centimeters. And somewhere between 5 and 5.5 centimeters is where we start to see a pretty big uptick in the risk of something bad happening to your aorta. And that's why we usually intervene somewhere in that range. And to put what does 5.5 centimeters look like? Well, a big Coke can is 5.8 centimeters. So it's a little bit bigger than that, but think about how big that is. It's actually huge. And the regular aorta, a sort of a normal sized aorta, is like the size of the inside of a toilet paper roll, the roll in there, that it's probably about that size. So that's a huge difference. Next. When something bad happens to the ascending aorta, it's usually an aortic dissection. And that is that the inner lining rips and then blood goes out of the main channel of the aorta into something called a false channel or a false lumen. And so you don't rupture and just bleed out right away, which is often what happens with abdominal aneurysms when they rupture. These ascending aneurysms typically will dissect and not rupture right away, although they will eventually rupture if this is not treated. And one of the consequences of this kind of tearing is that it can actually knock off the blood vessels that are connected to the aorta, like the blood vessels to the brain, like the carotid artery, or blood vessels to your intestines or your legs. And so you can develop loss of blood flow because the tearing of the artery actually cuts the blood supply off. And so usually we think when someone has an aortic dissection that's what we call acute or immediate, that there's almost a 2% risk of dying per hour if it's not fixed. So we always want to try and fix aneurysms before they get to this point. Next. So why do aneurysms happen? Well, that's a pretty complicated question. A lot of it has to do with genetics. On the left, on the right panel there's a crazy slide with a bunch of different genes written there and compounds. These are all the different things that keep the wall of your aorta healthy. And that's probably not even a tenth of the ones that are actually involved. So it's really complicated. But there are some clear genetic syndromes, so a change in a gene that actually causes the wall of the aorta to not be as strong because some of the components are not created properly or missing completely. And Marfan syndrome, loeys-dietz syndrome, Turner's are all syndromes that are highly associated with aortic aneurysm. The most common reasons why we see aneurysms in our practice are bicuspid valve related aneurysms. So bicuspid valves have aneurysms associated with them. And I'll go into why a little bit later. And then also something called genetic non-syndromic. So they're aneurysms that run in the family. They're related to some kind of complex genetics, not the usual stuff, but something more complicated that's harder to understand. But the patient doesn't have a syndrome associated with it. So genetic syndromic conditions like Marfan's, and you can go to the next slide, actually. Genetic syndromes like Marfan's or loeys-dietz have a variety of different changes associated with them. So it's not just that the aorta is enlarged or they have an aneurysm, but there might be other skeletal features, bony issues, tendon issues, ocular issues, cleft palate, all kinds of different things that are associated. So those are syndromes, and part of those syndromes is the aortic issue. The syndromic genetic aortic conditions generally appear very young and often even in childhood. So in particular, something like loeys-dietz, who may see aortic valve and root aneurysms happening even in the preteen years. Next slide. The most common reason that we do see aneurysms in our practice here at Penn is actually related to bicuspid aortic valves, or what we call BAVs. BAVs are really common, unlike things like Marfan syndrome or loeys-dietz that are really rare. BAVs are actually pretty common. 1 or 2% of the overall population, much more common in males. So there is some genetic component to it. And interestingly, if you have a bicuspid aortic valve, the prevalence in your first degree relatives is almost 9%. So it's 4 or 5 times higher than in the general population. So there is clearly some genetic element to bicuspid aortic valves, although it's not really well understood yet, even with the best science. And what is a bicuspid aortic valve? Well, it's something that you're born with. And and essentially, as you see in the panel there on the right, instead of having a valve that has 3 components that open and close, it only has 2 components that open and close. And it can follow different patterns. The one I'm showing there is the most common one, which is 2 of the leaflets are fused together, and one of them is kind of a normal leaflet. Next. So bicuspid valves are very associated with aortic aneurysms, and about 20 or 30% of people will develop an aneurysm 10 to 20 years after the diagnosis of a bicuspid aortic valve. 80% of bicuspid aortic valve patients will have an aorta greater than 4 centimeters over their lifetime. So it is common for people with bicuspid valves to have large aortas. There's an 80 times higher rate of aneurysm formation than the general population. And at least in our practice, 50% of all root operations in the patients over 50 are bicuspid related. Next. The reason why aneurysms form in bicuspid patients is complicated. Part of it, we think, is related to the genetics of why it happens in the first place. But the other part has to do with flow. That the flow going through a bicuspid valve is very different than through a normal 3-leaflet valve. And it actually can put a lot of stress on the aorta. The jet of the blood can actually be pounding on one part of the aorta the patient's whole lifetime, and actually cause it to stretch and develop an aneurysm. And these are different patterns of aneurysms that can form. You can go to the next slide.
Yeah, and Dr. Desai, real quick follow-up question for you. For a patient who's never heard that term jet before, can you explain what that means?
Oh yeah, absolutely. So you see those arrows of the coming out of the valve. So that's a pictorial representation of the swirl of blood as it comes out of our heart. And so we call that ejection, or the push of blood out of the heart, a jet. And you can see here the jets are going in all kinds of different directions, and they're pounding in some situations right on the wall of the aorta in specific orientations. And that, we think, causes a weakness. In a 3-leaflet valve, that jet goes straight up to the brain and doesn't hit the walls of the aorta.
Great, thank you.
Yeah, and you can have a next. And so you can develop different types of aneurysms with bicuspid valve, and that explains some of the different operations that you may have had or may need in the future for an aneurysm with a bicuspid valve. Sometimes they're just above what we call the root, or where the valve is. Sometimes they involve the entire root and ascending aorta. So the root, again, is that bulbous part down by the bottom where the valve is. And then sometimes the entire thing can be aneurysmal. And so those are all different patterns. And these are reasons why we do different operations for different pathologies. Next. And this is a bit busy here, but what I just wanted to show is in the figure, you can see there's different types of valve openings. So there's the kind where it opens almost like a fish mouth and you have 2 equal leaflets. There's the kind where there's 2 leaflets are fused together. That's panel B, yep. And then there's the kind where actually there really isn't leaflets at all. It's kind of like one huge leaflet that's fused together, and there's a slit in it. And this is the one that typically we see in childhood. So if someone has a valvular obstruction as a kid and needs a procedure as a child to open it up, that's frequently what we see. And then also most people who have stenosis or narrowing of their aortic valve in the younger age groups, so in the 20s, 30s, is often this third type, which is pretty rare overall. Generally speaking, the second type is 80% of people with bicuspid valves. Next. So what happens to people with bicuspid valves? Well, so if you didn't know you had a bicuspid valve and just went and someone heard a murmur, or they did an echo on you for some reason and they saw, oh, you have a bicuspid valve, you didn't have any symptoms, it wasn't bothering you at all, this is what your natural history is. They actually did a screening study to look at, just did echoes on an entire county of people in Olmsted County, which is near where the Mayo Clinic is. And what they found is that if they diagnosed an asymptomatic bicuspid valve on that echo, the patient didn't know about it before, and they diagnosed it then, that the overall survival actually is still very good. Even if you have a bicuspid valve, for the next 20 years at least, the chance of you being alive versus someone who didn't have a bicuspid valve being alive was the same, 90%. But a third of patients will develop symptoms over the next 20 years. And in the graph on the right panel there, that's a graph showing what happens if when they did that echo, even they had no symptoms with your bicuspid valve, they saw that the valve wasn't normal, like it wasn't working normally. It's bicuspid, but it wasn't working normally. That there's a 75% chance that within the next 10 years or so, you're going to have surgery on your valve. But if the valve was working completely normal, the risk was only about 20%, less than 20% in the next 20 years. So what your valve looks like at the time of diagnosis has a lot to do with what happens to you in the future. Next. The syndromic, the non-syndromic genetic cases, so people who don't have other abnormalities but just have the aneurysm, is an important group. It's another group. We don't understand a lot about them. We don't know what the genes are, but there are people who have a family history of an aneurysm and they have an aneurysm. And those people have a much poorer prognosis than if you didn't have a family history. So 3 times higher yearly risk of having a type A dissection, and typically happens 8 years earlier than someone with the same size aorta, but no family history. So it is an important thing to watch out for. Next. And this is a great example of it. This is what we call a tale of two brothers. This is 2 patients that Dr. Bavaria and I took care of. And one was a gentleman presented, he was 57 years old. He had an acute type A dissection, so that aortic dissection, had emergency surgery. He actually lost blood flow to his leg at the time, had emergency surgery. The aorta, but actually, the aorta wasn't aneurysmal. He didn't know family history of it. Really kind of walked in with no problems. And Dr. Bavaria operated on him and saved his life, and he had a very good result over the long term. Fast forward this 9 years. Next. This is a patient that I took care of, but also a 57-year-old male, presented with an acute type A dissection, lost blood flow, had a loss of blood flow to the leg. So same presentation. The aorta wasn't that big. It wasn't aneurysmal at the time, otherwise healthy. And he had a successful repair. And, a month later, I was talking to him in the clinic, and he mentioned, oh, his brother had emergency heart surgery years ago for something similar. And it turns out that these 2 brothers, you can go to the next slide, had almost an identical presentation at an identical age with an acute aortic dissection. It just tells us, number one, there's so much about this disease we don't understand or know, but 2, like, what can we do to really be proactive about preventing these kind of things from happening, and understanding the genetics, looking at imaging and intensive medical therapy. When should we have operated? If we'd known about it, when could we have operated to try and prevent something like that? And how do we help families to deal with the burden of emergency surgery, life and death experiences, and then knowing that children or other members of the family may be affected as well. So these are all things we think about a lot as we consider our sort of comprehensive aortic program here at Penn. Next. And in the realm of genetic testing, this is kind of a busy slide. It's kind of a clinical decision-making slide, but the key things I want to stress here are that having a family history, as I showed you, having a family history of aortic aneurysm is really serious. We do recommend that if anyone has syndromic features or early age of onset or has a aortic dissection, that genetic testing really should be done in almost everybody. And that also, if there is a family history of thoracic aortic aneurysm, that all first-degree relatives of that person should be screened, either with an echo or a CAT scan. And I think that's emerging, and that's how we want to avoid some of the problems that we see with multiple family members having aortic dissections because we just didn't know about them. Next. So how do we treat aneurysms? Well, one of the things we want to do is to try and prevent them from growing or tearing, right? Blood pressure medicines, I'm sure your cardiologists have all talked to you about. being on blood pressure medicines, beta blockers like atenolol, metoprolol, losartan, which is an angiotensin receptor blocker, are all very good at preventing growth of the aorta in patients with syndromic aortic conditions like Marfan's. We don't know that they're as good for people with bicuspid or other aneurysms, but we still, recommend being on one of these agents for blood pressure control. We ask people to avoid heavy weightlifting, not more than a third or half of their body weight, and often even less if the aorta is larger. 50 pounds is often a restriction we'll put, not to put too much strain on the aorta. Avoid high G-force or sudden decelerations like fighter jets, roller coasters, or high impact sports as well. Next. Fluoroquinolone. So antibiotics like ciprofloxacin, levaquin, which are really commonly used for bronchitis or pulmonary conditions and sometimes UTIs or urinary tract infections, have been shown to double your risk of having an aortic catastrophe. So patients with aneurysm should never take these medicines unless there are no alternatives. And really advocate on your own behalf for that, because this is something I feel like the medical community really is not aware of enough. Next. And then when do we intervene? Well, it really depends on the person and what they have. So genetic syndrome, we're looking at operating at smaller numbers like 4.5 to 5. Bicuspid with some valve dysfunction, somewhere between 4.5 and 5. Bicuspids with normal function between 5 and 5.5. And non-syndromic familial between 5 and 5.5. And if we know something about their genetics, like that complex panel we see on the right side, then we might follow those guidelines in terms of when we do it. If it's growing a lot, we'll operate earlier. And if we're in there doing an aortic valve replacement because the aortic valve is not functioning, then we'll usually do it at 4.5. Next. We do index to size as well. So we know that larger people do have larger aortas. And so this gentleman here, who I think is the tallest person who ever lived, was 8'11". So I don't know how big his aorta was, but it was probably at least twice as big as mine is. And so that's, what's normal for one person isn't necessarily normal for another person. So we do index it to the size as well when we make decisions about whether or not to operate. Next. And then finally, when we start talking about what we're going to do, like what are the treatment options for someone who has an aneurysm with or without valvular disease, we're thinking about what's the status of the aortic valve? Is it narrowed or is it leaking? Because that helps determine what we're going to do. And where's the location of the aneurysm? So is it down in the root, in the mid-ascending, or up into the arch? And so our algorithm usually is if there's aortic stenosis involved, so the valve is narrowed, it doesn't open well, it's calcified, it has like chunks of calcium in it, it's not flexible and pliable and elastic anymore. Those type of valves we typically need to replace. And valves that are leaking, sometimes we replace them, but we usually try to repair them if possible. Next. So in terms of ways to replace, so again, we're looking at replacing the aorta, replacing the valve. The first panel here is a look at replacing the aorta and what's called a root replacement. So you're replacing the root, the aorta, as it enters into the heart, the valve as well. And really importantly, in that part of the heart, that part of the aorta is where the coronary arteries come off. So we have to put those back into our graft. That's called a coronary artery reimplantation. We call them buttons. And then that white material you see there, the tube, is Dacron. So it's polyester that's been treated to be safe inside a human being. And it's a polyester cloth. That's what those grafts are made out of. And we've been using those since the 1960s, and they're very durable. Sometimes we don't need to replace the root, so we actually replace just the valve because there's stenosis, and we replace the aorta. We can use a pig's root. So we can actually take the pig's valve and aorta and use that to replace the person's aorta. Sometimes that's not long enough and we'll add some Dacron to it as well. Or we can use, and this we use in infections often, is a homograft or a human preserved aorta. So a cadaver aorta that's been frozen, and we can use it to replace a living person's aorta. Those are all biologic replacements. On the other side are mechanical replacements. So using a device that's made out of carbon and metal instead of the biologic valve. The advantage of the mechanical valve is it lasts forever. The disadvantage is that you have to strong blood thinners like Coumadin for the rest of your life, and you can never miss a dose because those valves will clot otherwise. The tissue valves will eventually break down, and that can be 7, 10, or even 25 years later, depending on what's used. Next. When the tissue valves break down, these days we have transcatheter valve technology. There's been a lot of questions about it today. And so we can actually replace it with a transcatheter valve. The key thing to remember there, though, is that it's not always possible to replace a failed surgical valve with a transcatheter valve, because sometimes the valve is too small. There's not enough room in there to actually do it. So the first operation you have needs to be a really good operation to be able to have a TAVR later. Next. And then finally, something that I think has really come back into favor and is really becoming a big part of our practice is doing the Ross procedure. So the Ross procedure is an operation that is designed to give you a living valve replacement. That is putting something in that's biological, that can grow with you, that can get bigger with exercise and stay healthy for the rest of your life. And what it involves is taking a different valve from your body, the pulmonic valve, which is on the right side of the heart, and putting it where your aortic valve is. So you take this whole trunk out, and Adam, if you want to just show the pulmonic root kind of being moved there, the other side, the pink. Yep. Yeah, that's it there. Perfect. That we take that out from the pulmonic side and put it on the aortic side. And we may replace some of the aorta with Dacron at that time as well. And the question is, what do you do on the pulmonic side? What do you do with that valve? Well, that's where we put a homograft in, so a cadaveric human. The advantage of this is that on the right side, it's the low pressure side of the heart. It's the only thing that right side of the heart does is take the blood, collect it, and pump it to the lungs. It's not, that valve that we put in there is not under a lot of pressure. So it can last a long, long time. And on the aortic side, where the valve is under a lot of pressure, it's your own valve. It's one of your own valves. It can work just like your own aortic valve did. It can last a lifetime. In the little graph in the corner there, on the left-hand corner, that's one of the longest series of Ross procedures out there, that even out to 25 years, there can be a 95% freedom from having any further surgery on your valve. So this is an operation that has a potential last for a long time, and in a lot of people forever. But it's a more complicated operation. It's a much bigger surgery, and it does require certain anatomy to be just right to do it. But it's something that for younger people, we are doing more and more of. Next. And here's a couple of examples of that. So this is a patient who had a unicusp valve when he was young, and he amazingly had severe aortic stenosis for probably 15 years and had compensated with it. And you can actually see that this is an MRI picture where you can actually see the blood getting ejected out of the aorta and hitting the wall of the out of the aortic valve, hitting the wall of the aorta, and actually causing it to bulge there. That's like seeing how these aneurysms form in real time. And so we did a Ross on him. And he came back to me a few months later and said, I haven't breathed this well in 15 years. So, it's amazing what having a well-functioning aortic valve can do. And he has a durable solution that hopefully will last for 15, 20, 30 years. Next. And what about bioprosthetic valves? So there's a lot of patients who are young, if you just play the video there, yeah, who have bioprosthetic valves. And in young people, bioprosthetic valves don't last that long. If they last 8 to 10 years, we're happy. And sometimes you get 15, but it's rare. This is a patient who had a valve done about 7 or 8 years ago. If you just want to play it one more time. Thank you, Adam. The bioprosthetic valve is just not moving very well. That part, these are some echo images that make it a little bit hard to interpret, but on the next picture, you see that it's just not opening. See, that's not opening very well. It should be opening all the way to the wall of the aorta. So anyways, we took that valve out and we did a Ross on him. So we actually were able to do a really lifelong operation on him at that point. He had a successful procedure and has a perfectly functioning valve now. Is doing really well. So, there's, even if you've had another operation, it's still possible to have a Ross and convert everything back to a nice biologic solution for you. Next.
Yeah, and Dr. Desai and Dr. Bavaria, and for everybody in the call, just so I actually had a Ross procedure done. It's been 16 years since I had that procedure, and I have had no complications since then. And I just really want to acknowledge the Penn Medicine team for taking on this procedure. I understand how it is much more complex, but again, if you create that long-term result for your patients, it's a big, big win. And I just want to let anybody know, if anybody has questions out there about the Ross procedure, don't hesitate to email me and I'll get back to you as soon as possible. My email is adam@HeartValveSurgery.com. Sorry for interrupting, Dr. Desai.
No, that's great. That's amazing for you to share that with us and your experiences. Okay, I'm going to hand it to Dr. Bavaria now.
Great. Well, listen, thank you so much, Adam and Nimesh. So I know we don't have a whole lot of time. I want to get through this so we have plenty of time for questions and answers. So I'm going to move pretty quickly. But one of the things, especially for leaky valves, is can we repair the valve? And why is this so important? So now we're talking about something about reparative surgery. Next. So in many cases, when we have leaky valves, okay, or we have aneurysms with relatively normal valves, we can actually repair or retain these valves. And one of the ways we do it is called a David operation, or valve sparing root procedure. And what you can see is what we do is we take out the aneurysm and then we reimplant a kind of a normal valve, whether it's a three-cusp valve or a bicuspid valve, into this new root. And this root is designed specifically for you. In other words, it's custom made in 3 dimensions for each individual patient. And then we either keep the valve and don't have to do anything to it, or for example, in a bicuspid valve, we'll repair the bicuspid valve at the same time. So this is a valve sparing repair, and is really a very, very good thing. This is kind of the main, probably for leaky valves, the main issue. Next. And here's an example. That's a Marfan's patient on the left with a gigantic aneurysm. You can see it. And then on the right side, you can see the new root, which is the white stuff. And we've reimplanted this beautiful valve inside this new root. And this will last for a long time. And someone asked, is the aneurysm portion of the operation forever? And usually there are forever. And when you have a valve that looks like this, that's probably going to be almost forever as well. So this is really a major advance in valve surgery, especially for leaky valves. Okay, next. And now bicuspid valves, which you saw before was a three-cusp valve. So this is a bicuspid valve, and you can see we've already taken out the aneurysm on the left, and we have a bicuspid valve. And in this kind of case, we can take that valve, put it back into this new aortic root, what's the new aneurysm repair, and then repair the valve so that the coaptation zone, you can see that line on right in the middle, is nice and what we call together. And I'll use it here for everybody. We like to get what we call the position of prayer. Okay, so everything is perfectly stable. Okay, and not have any holes in it like you see there. Next. And here's just some of our personal data. This is our first 336 patients. We're probably up to close to 500 now. But this is our 336 patients. You can see TAV is three-cusp valves and BAV is bicuspid valves. And you can see that out to 10 years, the results are really, really good for freedom from all-cause mortality. So only like, you can see that number down the bottom. It's only a 9 to 10% mortality rate at 10 years, which is kind of the normal for these patients. And everybody, the average age of these patients is probably in their 50s. And then freedom from reoperation is also very, very small. So it's only, if you look at the line there where it says 10, it's 92 to 96. So that means that there's only 4 to 5% reoperation rates out to 10 years. So the bottom line is results are really, really good. And it doesn't seem to make much difference whether it's a TAV or BAV. As you can see, the lines are basically the same. So very, very good results with these cases with leaky aortic valves. And this is critical. When you have an aneurysm, this is a big deal, because if you have an aneurysm and your valve's pretty reasonable, You don't really want to throw that valve in the bucket. A lot of surgeons might do that, but we don't do that here. And we're going to spare or repair your valve under those circumstances. Next.
Hey, Dr. Bavaria, before we move on, real quick for the patients out there, aortic valve repair. We hear a lot about aortic valve replacement. Aortic valve repair, is that something that's done at all cardiac centers, specialized centers? Can you talk about the availability for a patient to actually have something like this even done?
Yeah, aortic valve repair is mostly in specialized centers at this point. Three-cusp aortic valve repair or three-cusp aortic valve sparing is a little bit more mature than bicuspid valve repair. Bicuspid valve repair is really only in a few centers at this point. It's getting better and better. We have a 17-year experience with this now, and our first one was done in November of 2004. We think this is a part of the future, especially for leaky bicuspid and leaky three-cusp aortic valves.
Great, thank you.
Now, this kind of gets to what you were just saying, Adam. This is a slide out of Yale, actually, looking at whether a center that does a lot of cases does better. And what you can see here is that in the bottom part, if the case in the cases of a group that does 400 cases a year down the bottom right-hand side, you can see that the mortality rate is very, very low for aortic surgery. And you can see that if you go to a place that only does 25, where that green line is, then the mortality rate is a little bit higher. And if a place does less than 25, I would tell you not to go to that, at least from the standpoint of this particular slide. It's from Yale. Next slide. And this is just to show you that we're doing some new research. This is from our engineering laboratories, looking at bicuspid valves and how we're doing some next-gen imaging and computing to try to figure out exactly how we're going to repair these valves before we even repair it. So we kind of figured out on the bench top before we even get into the operating room. Next. So that's kind of new stuff. And this is a new kind of first-in-human operation. This is just Adam wanted us to talk about what's in the future, what we're looking at. Here's a patient who had a dissection. I must say she was a Jehovah's Witness, so she wouldn't take blood. So we couldn't do an open operation in her. And we basically did a aneurysm and aortic dissection repair utilizing aortic stent grafts from basically the aortic valve, as you can see down there, all the way to the mid aorta. And this actually was one of the first operations done in ever with utilizing this technology. Next. Now, lifelong strategy for aortic aneurysms and valve disease, kind of my algorithm or the way I approach it is, first of all, repair whenever possible. That's number one. Number two, if you're less than 55 years old, repair, replace, maybe a Ross procedure. If you're going to do that, large tissue valve, Ross procedure, or a mechanical valve. Okay. If you're 55 to 70, we use surgical aortic valves with a tissue or mechanical valve, with a root or descending if necessary. And this is guideline directed. The TAVR, people ask a lot of things on the chat. TAVR, the average age for the low risk trials for TAVR is 72 to 74. Not many patients have been treated who are less than 65 with TAVR in the United States at this point anyway. Remember, there's a high prevalence of bicuspid valve in patients under 70, and TAVR is not quite as good in bicuspid cases as it is in three-cusp valve patients. 70, 80-year-olds, if they're bicuspid and they're low risk, we will do a straightforward aortic valve. If they're high risk, we will TAVR these patients. If you're over 80, we'll try to TAVR you if we can. Remember, screen all your relatives and be aggressive with aneurysms in young patients especially, because the aortic part of the operation is forever. Next slide. And now we're questions and answers, Adam.
Yeah, so Dr. Bavaria, Dr. Desai, thanks so much for the prepared remarks. We've got 40, actually, no, in total, we've got 56 questions. So I don't know that we're going to get to all of them, but we're going to try and just go into rapid fire Q&A. This is coming from actually Michael Z. Dr. Bavaria, you might recognize the Z. He's one of your patients. He says, Adam, is there any progress in the development of the use of TAVR procedure for patients with aortic regurgitation?
I'll let Nimesh answer that one.
Yes, there is. We do it. We already do it in certain situations, although not in aneurysm patients because it doesn't fit very well in that situation. But there are some newer technologies coming out and none of them are commercially available in the US yet, where instead of the TAVR valve pushing on the calcium to stay in place, it actually grabs onto a leaflets to stay in place. So I think there's stuff coming down the pipeline, but there really isn't anything today that I would say is ready for prime time.
And so, Dr. Desai, you'd say clinical trials happening, stay tuned. We need more data to figure out whether or not we've got a safe and effective device. Is that about right?
That's exactly right. And they're not, I think it's still pretty early phase in terms of getting commercially available here. So I think we're years away from it.
Great. And so Penn Medicine is participating in those clinical trials, correct?
Yeah, we're going to be in on everything that comes our way. We always have been.
Thanks. All right, let's moving on to the topic of calcified heart valves from Donald. He asked, Adam, my doctor indicated that my heart was not in the best shape because of calcium buildup. Can you help me understand the progression of a calcified valve? Do most patients with calcified valves need heart surgery?
Yeah, I'll answer that one. So this is, first of all, the most common reason why valves need to be replaced is because of calcification of the valves. The calcification happens, relatively slowly over a period of years, but it's kind of it's not linear. In other words, the more calcified it gets, the faster it gets calcified. So eventually, a calcified valve will start to really load the heart, and the heart muscle is kind of stressing. It's like a truck up a hill, and that is when you end up needing. That's when you start getting symptoms, and that's when you end up needing to have your valve replaced. One of the things that I think is interesting is that acquired valve disease, three-cusp valve disease, actually happens faster than bicuspid aortic valve disease. So that's a new data from the last 10 years. We didn't think that way beforehand. So that's kind of an interesting situation. Acquired valve disease actually is more accelerated than congenital bicuspid aortic valve disease.
Got it. And just so for the patients, when you say acquired aortic valve disease, is that just throughout your lifetime with the valves opening and closing versus being born or something?
Yeah, acquired disease, it means it's not congenital. You weren't born with it. And about 3 to 4% of the entire population of the world will eventually have a calcified valve, just part of your genetics. And this is a three-cusp valve, so this is a normal valve. Bicuspid valve, in general, will almost always end up requiring a replacement before a normal lifespan of 85 to 90 years. So, but that's a congenital issue.
Got it. All right, let's keep going. And we're moving on to Ari. Ari asks, are there non-invasive techniques like TAVR to treat aortic aneurysms?
Yeah, so, we showed you that picture of the dissection we treated with stent grafts. The ascending aorta is a super hostile place for stent grafts because it moves up and down and twists and grows bigger and smaller with every heartbeat. And so although we do lots of stents to treat aneurysms in other parts of the aorta, this is still an area where things are pretty new. And we've done, probably about 25 or 30 of them, maybe a bit more than that, for very unusual scenarios that we've run into over the years. But that's 20, let's say that's 30 out of how many ascending aortas have we done over that time frame? Maybe 3,000, right? So it's a very small proportion of them.
Got it. And do you think the prevalence of that procedure will increase over time, or it's still we don't know?
I think it'll increase over time, but it's not quite ready for prime time, especially in the ascending aorta. But I think in 10 years we'll have more. It'll be better, but we're working on it pretty aggressively, but we're not quite there yet.
Got it. All right, moving on to echocardiograms, which are often very confusing for patients. But here's a question from Lou about a bicuspid aortic valve. He says, what echocardiography parameters do Dr. Bavaria and Dr. Desai feel are the most significant when monitoring a BAV?
Right, so we're looking at the degree of stenosis or narrowing, and we're looking at how much leakage there is, and we're looking at how big the aorta is. So those are the three things. The third one, CAT scan, is probably just as important, but the other two you can only derive from echo. So of those, the valve leakage, there's different ways to quantify them, and that's a little bit more complicated. But for the stenosis side, which is the majority of patients, we're usually looking at something called a valve area, and the mean gradient, and the what we call peak velocity. And the one that's the most correlated with developing symptoms is the peak velocity. So that's how fast the blood goes through the aortic valve. So imagine it's like putting your thumb on a hose, that if you make the hole smaller, it goes, the water squirts out faster. Same thing with your aortic valve. When the hole gets smaller, the blood comes out at a faster and faster rate. And so when that number hits 4 meters per second, that's when we know you have a severe stenosis.
Got it. Lou, I hope that helped you. I know it helped me. And let's move on to aneurysm devices. We talked about this a little earlier. Jerry asked Adam, we hear a lot about the different heart valves out there, but what about aneurysm devices? How are those devices changing?
Well, that's a good question, and they're not really changing that much. The grafts that we use to it's like pipe fitting 101. We basically take the aorta out, the pipe out, and then we put a new pipe in. The new pipe is made out of a woven Dacron graft. These are very, very tightly woven grafts. It's a textile. The closest I can tell you, it's a little bit like a sail on a sailboat, which doesn't let any air through, but it can move around. It can take the curves. So now these grafts have been improved over time. They don't bleed as much as they used to. In fact, they don't bleed at all now, and they last a long time. In fact, they last forever. And so they're very, very good, but they're kind of what I would call iterative changes in the grafts. So they're getting better, but it's not a giant leap. The giant leap is what we just talked about, 5 minutes ago, which is endografting of the aorta in the ascending and arch. And as Dr. Desai says, the ascending is a particularly hostile area, but we're working on it.
Got it. Thanks for that. And moving on to Nick, some procedure we haven't talked about yet today, which is the Ozaki procedure. He asked, what should I know about the Ozaki procedure for aortic valve disease? Is it used for both adults and children?
Yeah. First of all, the Ozaki procedure, sometimes with the Ozaki procedure, you need to go back to history. So the Ozaki procedure was invented for places that don't have enough, capital or whatever, to actually do valve surgery. Places like, the lower income countries of the world, because you're using your own pericardium, so it's basically a free valve. Now, the Dr. Ozaki himself has a pretty good results, but we still haven't really had excellent or robust verification of those results. And one of the things so I actually don't do the Ozaki procedure because I'm not really quite sure that it's the right thing to do. And remember, you're using your own pericardium, and I don't know. The valve companies spend billions of dollars figuring out pericardial valves. So I'm not quite in the Ozaki camp at this point, but I'm not going to say that it's not a decent procedure. But that's just my personal opinion. I don't know what Nimesh would say.
Yeah, and I would agree. I think it's a very niche procedure. I think in countries that can't, afford prosthetics, it's a good procedure. In certain situations with infection, apparently it's a good procedure. And if you have a very, very small root, it can be a nice procedure as well. But I think there are a lot of questions about long-term durability with it.
Great. Well, we have time for one more question. I think we can end this on the idea of risk, because that's something that patients often have is, what is my risk going into heart surgery? Shirley asked, what is the risk of an aortic valve and aneurysm surgery for an 83-year-old patient?
Yeah, so this is the risk of both an aortic valve and an aneurysm. So for an 83-year-old patient, the risk is not zero, that's for sure. In places like our place where we do a ton of these things, the risk is probably not that great from the actual surgery itself from a standpoint of death. There might be a certain issue. If your lungs are bad, you could die from a pulmonary issue later on. But if you're pretty robust health, your risk of death from the operation is probably pretty low, like 2-3% or so. The biggest risk in an 83-year-old, there would be a slight risk of stroke. But I think that in our practice anyway, we start really thinking about not doing cases at 85 or 86. In my personal practice, open aneurysm surgery with valve surgery, exactly like this question. My oldest patient is 88.
Wow. Wow. Well, great. On that note, unfortunately, we are running out of time, but please don't hang up the call just yet. I want to go ahead and extend a tremendous thank you to Dr. Bavaria, Dr. Desai, the Penn Medicine team for supporting us and getting us all together to talk about the advances in aortic valve and aneurysm surgery. Dr. Desai, Dr. Bavaria, thanks so much.
Thank you.
Thank you, Adam.
Yeah, and for all the people on the call today, I want to thank you for taking the time, getting educated, learning about aortic valves and aneurysms so you feel educated and empowered. And with that said, we're going to wrap up the webinar. And if you could please complete the survey that is coming up on your screen right now. Thanks so much, everybody.